All right, so without further ado, please allow me to introduce your speaker today. Diana McFarlane is a gastroenterology physician assistant with specialized expertise in gastroenterology in in gastroenterological motility disorders, including gastroparesis, pelvic floor disorder, IBS, and chronic abdominal pain. Diane is also passionate about medical education, and she speaks professionally at medical education events as well as patient education programs. So without further ado, I'll turn it over to you, Diana.
Hello, can everyone see me okay?
Yes.
Wonderful. Well, my name is Diana McFarlane. I'm a PA, and I'm very happy to be here with you today. And I'll be talking about advanced treatment options for gastroparesis. I'm going to pause for 1 second here. Okay.
There we go. You're good.
Okay. So today I'm going to start by talking specifically because we're talking about a specific patient population here who has gastroparesis. And I feel like most of our participants here likely either have nutrition support in the setting of gastroparesis, need nutrition support in the setting of gastroparesis, or maybe care for others who are in that position. So we're going to talk a little bit specifically about what gastroparesis is, what it means, and what it means in terms of needing nutritional support. But then beyond nutritional support, what other options are there? And I feel like that's a question that patients come to my clinic all the time to ask. We're going to talk specifically today about one of those tools called the gastric neurostimulator and some pyloric interventions. And then we're going to take some time to listen to Vince's story and explore some of your questions and have some discussion. We also want to share some resources and support today that you can take coming from this visit. So next slide. Okay, so let's talk about what gastroparesis is. And as a quick reminder, when we bring up the Entera device, we'll be sticking with what the FDA regulations state about that device, and I'll explain what that means a little bit later. But first of all, gastroparesis. I'm sure all of you know what this is, but I think it's important for us to talk about what it includes. So gastroparesis is a medical condition that prevents the stomach from emptying, but it's not as simple as that. It's not just a delayed emptying. It's a neuromuscular disorder, meaning that it causes symptoms of nausea. It often leads people to throw up. They may throw up food they just ate or food they ate hours before, or feel like they're going to throw up at all times. They may have problems with their blood sugar because the food isn't processed in their stomach as quickly as it should be. They may develop malnutrition, have trouble with epigastric pain, bloating, fullness, not be able to eat much food at a time. We know that diabetes causes gastroparesis, but we also know there are many other causes of gastroparesis, including viruses, connective tissue disorders, and other disorders of the nervous system. And in many cases, we don't know exactly why someone developed gastroparesis. So how do we go about diagnosing this? Because there are a lot of things out there that make people feel sick, right? Medications can make people feel sick and other medical disorders can. So how do we narrow down that a patient has gastroparesis? Well, we always start with a very detailed history. And this is where I spend most of my time during the first consultation is when did this start? How did it start? What are the symptoms? How do they act? What's the pattern? What are the triggers? So we go through a ton of questions about how this works for you. And then we do a complete physical exam. And then we talk about diagnostic testing. And specific to gastroparesis, we need to perform an endoscopy, an upper endoscopy, to ensure that there's nothing in the stomach, like an infection with a bacteria or an ulcer or some other cause of nausea and vomiting. And then we need to perform a functional study called the gastric emptying test, where we have you eat food and then watch to see how long it takes to get out of the stomach. Those are the basic diagnostic tests for gastroparesis. So following that evaluation, we then talk about, well, what is first-line therapy? And I'm sure that you are all experts on this at this point, but first-line therapy for someone who has diabetes is getting that glycemic control back into a normal range. Anytime the blood sugar is over 250, 300, and for someone who has persistent hyperglycemia, they're going to start to develop these symptoms just from the hyperglycemia itself, just from the high blood glucose levels. So we're going to try to get that blood glucose under control. Then we're going to talk about dietary modifications. How do we adjust the diet so that it is more comfortable to eat. And that's the basis here. How do we adjust the diet so it is more comfortable to eat? And that is different for different people. So we do have basic parameters that we follow when it comes to diet, but oftentimes these need to be customized to your specific scenario. We talk about offending medications. We all know that opioid or narcotic medications, we all know they cause pain, they cause nausea, vomiting, they cause delayed gastric emptying. That can be really tough for someone who depends on those medications for other reasons. So we have to work closely not only with our patients, but with their other care providers to try to find a solution for symptom management that doesn't at the same time worsen their gastroparesis symptoms. You've all heard of these Cadillac weight loss drugs, the GLP-1 agonists, or Ozempics and Mounjaros and Wegovys. Those drugs, they actually induce symptoms of gastroparesis. They actually cause delayed gastric emptying. And so we talk about if someone is on those medications and they have symptoms of gastroparesis, well, how do we navigate that? Then we utilize medications that can help. Some medications are in a category called prokinetics. These are medications that literally try to make the stomach pump. They also have some anti-nausea properties to them as well. In addition to that, we'll utilize what are called antiemetics. Antiemetics are a drug class that will help reduce the sensation of nausea and thus hopefully prevent vomiting. And then we follow along. How are you doing over time? Are you maintaining your nutrition? Are you maintaining your weight? How are your symptoms? How is your quality of life? Are you able to work? What other symptoms do you have? Do we need to manage things like constipation, acid reflux, bloating, bacterial imbalance in the gut? So this is our holistic approach to a patient who has gastroparesis. But upon reevaluation, if a patient still has symptoms of nausea and profound vomiting, inability to tolerate enough nutrition and hydration, we need to start to think about other advanced therapies. And so, of course, this is where nutrition support would come in. We utilize enteral nutrition and TPN. Other therapies we can offer are gastric electrical stimulation and pyloric procedures. Some of them are surgeries, some of them are endoscopic procedures to try to reduce the tension with emptying the stomach. So how do we decide if and when a person with gastroparesis might need additional nutrition support? I mean, it's pretty obvious, right? You can't drink enough water every day. You can't eat enough. So for me, it just starts out by, well, tell me what you can eat. Does that stay down? How often do you eat? How much do you eat? What types of foods do you eat? And we try to convert everyone to a very soft diet that is lower in fat and small volume portions throughout the day. We want to make sure you're getting enough hydration as well. But when we see a patient who is persistently failing that, and they've lost 10% of their body weight, or they've gained weight unexpectedly, or they're unable to meet caloric intake needs over a long period of time, they're at risk for malnutrition. This that you see on the screen here, this is called the Aspen criteria for malnutrition for adults. And this is what we use to help us understand when we're kind of getting into that category. One does not obviously need to meet all of these criteria, but we use these criteria to help align ourselves when malnourishment is playing a significant continuing role. And that's when we tend to offer nutrition support for patients who have gastroparesis. The other really, really important part of nutrition and gastroparesis is that we recognize that people who suffer from gastroparesis have to avoid a lot of foods that we generally depend upon for our nutrient sources. So it's very, very common for someone who has gastroparesis to experience deficiencies, especially in vitamin D, B12, and iron. And so when we partner with our dietitian partners, and when your gastroparesis provider partners with you, they're not only thinking about if you're maintaining your weight and your nourishment and hydration, but they're thinking about nutrient malnutrition. So when I partner with my dietitian, there are multiple types of things I want the dietitian to do with our patient. I want them to engage with the patient to teach them about how to eat if one has gastroparesis. But in addition to teaching and advising, I also want them to evaluate for whether or not someone might meet malnutrition criteria and whether or not they might have specific nutrient deficiencies. Once we find those nutrient deficiencies, we want to continue to partner with our dietitian in terms of trying to add in foods that might be tolerated, but also have those nutrients in them, or adding supplements as needed to supplement that oral nutrition. When we do decide to use enteral nutrition or TPN, we continue to partner with our dietitian colleagues to design what that supplemental nutrition will look like and how that should be adjusted over time as scenarios change. So when I look at the big picture, when it comes to supplemental nutrition, nutrition support for someone who has gastroparesis, of course, we want everyone to be able to tolerate an oral diet, right? And that's just not a reality all the time. But I have seen my patients transition along this continuum over time. What I mean by that is I might start out and see that a patient's tolerating some oral nutrition. Maybe they undergo a flare of gastroparesis and they have to change their diet to liquid. Maybe they have to get support with their symptoms in order to tolerate an oral diet. And so we really try to work on that. And we try, again, the focus here is on comfortable nutrition. If it is completely uncomfortable and an ongoing way uncomfortable, then that is where we need to start thinking about options. So we may then try enteral nutrition, and we can place different types of feeding tubes. One of the feeding tubes I call the tryout feeding tube is the NJ tube, to make sure the enteral feeds are going to go okay and that that's going to be comfortable. And if we decide to do that and give it a try and find that, no, this really is helping to get nourishment and feel more comfortable, we can go ahead and place one of those longer term feeding tubes, like a direct peg tube with a jejunal extension on the inside. We don't tend to use a lot of just pegs, just gastrostomies, because of course putting liquid food into the stomach is where the problem is. So we do try to put an extension tube in down into the deeper part of the small intestine. And then, of course, when that fails, then we're faced with, well, what do we do now? You know, sometimes we can use IV fluid as a support on top of enteral, and we find a good balance there. But when that still doesn't work, we'll sometimes need to use TPN. And that, of course, is IV nutrition put through a central line. And the goal with all of these steps is to make sure we are finding adequate nutrition sources, adequate hydration sources, and a comfortable form of nutrition. Of course, we always will have the goal of trying to get back to oral. That means we want to try to provide enough care that we can get back to that more comfortable oral nutrition if possible. But what that means at that point is that we're probably going to be talking about advanced therapies that can help bring us to a place where it's more comfortable to eat solid foods. And any of these options are okay to be on at any time. And we need to support our patients as we go through each of these steps and make these decisions. It's always a shared decision and a risk-benefit conversation about what's going to work best at any given time. So once someone has a feeding tube, for example, or once someone is on TPN, for example, that is not the end of the road. That just means that is the way in which we are supporting one's nutrition. But if there are still bothersome symptoms of nausea, vomiting, fullness, trouble with eating, what else can we do? So I'll quickly talk about one option called Botox, and this is where we use Botox botulinum toxin, and we inject it into the pyloric muscle. The pyloric muscle is a circular muscle at the very end of the stomach. If you imagine the stomach is like a bag, at the end of the stomach is a muscle that opens and closes to allow food to come out and go into the small intestine. The idea here is if we inject some Botox into that muscle, we're going to force it to be in a more relaxed position. If that muscle is more relaxed, perhaps the stomach, even though it may not empty as well, is going to have an easier time emptying. Unfortunately, with Botox injections, the studies we have to date really don't show much of an improvement over placebo. So someone who gets a fake injection of Botox, someone who gets a real injection of Botox, we're not really finding much of a huge difference there. Now, that being said, there are some people who have found that Botox has helped, and sometimes they'll get repeat injections over time. It's not a long-term treatment, and it's currently not recommended by our professional GI societies because the outcomes are so mediocre. But it is something that we do entertain and talk about. We do it for patients. Sometimes it's a less invasive option people want to try first, so it is an option that we do talk about. We can also run into trouble with insurance coverage for Botox, so that's something we have to, go through all the steps with a patient on. So pyloric surgery. So same muscle, but instead of putting an injection of a medicine into that muscle to force it to relax, we actually make incision. So if we do it by an upper endoscopy, where we put you to sleep and we put a camera down and we go down to the pyloric muscle, if we make a cut in that muscle endoscopically, that's what's called a GPOM, gastric peroral endoscopic myotomy. If we do it surgically, we're going to do usually a laparoscopy, so making the tiny incision ports into the abdominal wall and going in with instruments and making a cut in that pylorus muscle from the outside of the stomach during an operation. And that way the patient would be in an operating room with a surgeon. We essentially, from either side of that muscle, are making an incision in it to force it into more of an opened position. And the goal with pyloric intervention is really to improve that fullness, that inability to eat much, and that vomiting of food after eating. Results are somewhat varied, and this is an area of gastroparesis care which is currently under pretty close scrutiny. We have some studies that say that 70% of people have improvement. Some studies say 50% of people have improvement. So we're still sorting that out. We also have some studies that show us that maybe that initial improvement isn't lasting for very long. And so as more data comes out, I think we'll feel a little bit more confident in the pyloric options, and a lot of people pursue this option for care. Symptoms could return over time, and so again, that long-term follow-up with your gastroparesis provider is really important here. So the next therapy we're going to talk about is enterotherapy. Enterotherapy is an implantable device that is meant to relieve nausea and vomiting. This is called a gastric neurostimulator. This gently sends an electrical signal through the muscles of the stomach through a circuit. So you have the case that you can see at the bottom left and two leads through which electrical current is sent. This is not meant to be sensed by the abdomen. Some people can feel a slight sensation, but that's pretty uncommon. And this can be programmed externally, and we'll talk about that a little bit today. So how does it work? So the leads, which are those two electrical wires, those are placed inside the muscle of the front of the stomach wall. Those leads are then connected to the entera case, and that's called the neurostimulator. And the neurostimulator then sends this mild electrical signal through the front of the stomach wall. The goal with this work is to reduce nausea and vomiting. And you're going to hear me say this today, but our treatment endpoint goal here is to improve nausea and or vomiting by 80%. So we follow both of those symptoms very closely after this is implanted. Once it's implanted surgically, we can then adjust the device externally with a programmer, and we're going to continue to adjust the device until we reach that treatment endpoint goal of at least 80% symptom improvement with nausea and vomiting. We can turn the device off, and it can easily be removed. There's no permanent changes in the body after removal. It's a fully removable device. We'll talk a little bit about how this is implanted. So it typically takes an hour or two. It is done in the operating room, in a sterile operating room under general anesthesia. It is a surgery, so you'll be completely asleep. It may be done either robotically or laparoscopically, depending on the surgeon's comfort and expertise. And this is where just small incision holes are made in the abdominal wall to allow the tools to go into the abdominal cavity and perform the procedure. So during that procedure, the electrodes are placed into the front muscle wall of the stomach, and then the small device is implanted just below the skin, usually below the rib cage, away from the belt line, in a comfortable place. And you'll talk with your surgeon ahead of time about where the placement might be most comfortable for you so that you can continue to live your life every day in a normal way. So what does follow-up care look like? So many people will do this procedure as a same-day procedure, outpatient, and they leave after the procedure. Some patients need support from an inpatient perspective following the procedure, and that is individualized based on your medical history and needs, and this is something that the surgeon and patient will talk about together. You may have some pain for 4 to 6 weeks after surgery as you recover from the little incision sites, and your surgeon will work with you to treat that pain in that postoperative time. During recovery, it's important to follow the surgeon's advice about avoiding heavy lifting, exercise activities that may be too strenuous, things like twisting, bending, or stretching, until it's safe and everything is healed. You do not need to feel any sort of stimulation, so you don't expect to feel a stimulation effect from that. As I said earlier, there are some cases where it can be felt. It's usually not an uncomfortable situation, but it's pretty uncommon. And it's also very important to understand that when the gastric neurostimulator is in place, it still is important to follow a gastroparesis diet. That's one of the most important things to recognize. You may have heard out in the world that this is called a pacer. That's a nickname for this device. And it's kind of a bad nickname for this device because it doesn't actually pace or pump the stomach. It's not found to improve the gastric emptying time or make food move faster from the stomach. It's specifically designed to reduce nausea and vomiting. So it's really important to continue to follow the gastroparesis diet and to follow up closely with your surgeon and whomever the healthcare provider is that is going to manage the electrical stimulator. You'll be seeing them after surgery as well. Okay. Within 1 to 3 months following that surgery, you've recovered from the surgery, this is time to do a check-in. And we start by saying, how often are you nauseous? How bad is your nausea? How often are you vomiting? And what we want to do is take your early symptoms before you have the stimulator and compare them over time. And as we go forward, we want to make adjustments in the device to reduce the nausea vomiting. Again, with the treatment goal being at least 80% symptom improvement. This is done in office very, very quickly, painless. The connection between the device and the neurostimulator programmer is very smooth and easy and can be done from sitting in a chair. You don't even usually have to even remove clothing to do it. You may need to make some follow-up visits over time to make the adjustments customized to your needs. And it's important to remember as we adjust the device, that the device is powered by a battery. And over time, as energy is flowing through that system, the battery is going to become depleted. When that happens, the surgeon can easily replace the neurostimulator battery with a very simple outpatient procedure. It's important to recognize that the gastric neurostimulator has been around for a long time. It's going on, I think, 25 years now, and it has been studied extensively. There are hundreds of scientific journals and manuscripts on enterotherapy, and to date, there are more than 15,000 individuals who have received enterotherapy for symptoms of gastroparesis. I mentioned earlier that the gastric neurostimulator has a nickname, the pacer. So I'm going to talk about some other sort of common misconceptions that we encounter both from patients and providers alike in the field, and especially in some medical situations where a provider's not familiar with what Entera is, if they might not be familiar with what gastroparesis is exactly. So first and foremost, the Entera device, the gastric neurostimulator, is not a pacer for the stomach. It is a neurostimulator, and that means it is reducing the symptoms that are coming from the nervous system of the stomach that are driving nausea and vomiting. Enterotherapy helps make your stomach empty. We talked about that already as well today. Enterotherapy is designed to relieve nausea and vomiting, but it does not make the stomach empty faster. There are many out there who don't understand. They think FDA approval is not in place, but in fact, it has been FDA approved under the Humanitarian Device Exemption Act, which allows a device to be used to provide palliative therapy for patients who are suffering from chronic symptoms. And this has been around since 2000. It's been a long time, and there have been a ton of studies done on the device since then. There's also a misconception that it might not be covered by insurance, but in fact, it is actually covered by most insurers and has a positive coverage policy on most insurance plans to date. And there are some exceptions to that, and folks at Entera are available to help with that if insurance barriers do crop up. So at the end of this, you might be wondering, if you don't currently have a gastric neurostimulator, if it might be right for you. The general parameters around the FDA approval for this device are that one has been diagnosed appropriately with diabetes, or excuse me, with gastroparesis, based on either diabetes or an unknown cause, they are experiencing predominant symptoms of nausea and vomiting that has not been helped by diet or medications in over several weeks of attempts. And this is labeled for adults between the ages of 18 to 70. And if you meet these criteria, you can ask your doctor about Entera therapy and ask them if they think it's right for you. So what can you do in preparation for a gastroparesis consultation? And I want to preface this with gastroparesis is a more difficult, challenging area to manage if you're a healthcare provider. It is not something that we learn much about in medical school. And the other really important thing to recognize is that if you look at the FDA approved treatments for gastroparesis, you have one drug and one device. So Entera is FDA approved for the treatment of gastroparesis, and metoclopramide is approved for the treatment of gastroparesis. And many of us know that metoclopramide comes with some pretty strong side effect issues that we have to deal with. So what does that mean then? That means that our gastroparesis experts are actually using a lot of off-label treatments for gastroparesis, trying to find the most comfortable treatment option. And then what that means is that if you have to be specialized to know this, it may be hard to find a gastroparesis expert, especially if you live in a smaller town or more rural area. And so when you get referred to a gastroparesis expert, I want to frame this by saying, I want you to use that consultation wisely. If you can come with a detailed history, one of my favorite things is to ask a patient to bring a timeline. I want to know when this started and what happened along the way. What was going on before these symptoms started? Can we try to figure out why this happened? If you've had test results that have been done, especially the gastric emptying test where you eat solid food and see how long it takes to get out of your stomach, and the upper endoscopy, bring those along with you. There are some situations where we repeat testing, and there are some situations where we do some additional testing to try to figure things out. Please bring with you your greatest concerns and your questions, as well as questions about treatment options. There are also some additional resources that you can use on enteramedical.com that you can, like a symptom diary, a discussion guide with your care provider, and a way to track your symptoms over time so that you can give your provider all of that information in a very efficient and succinct manner. And the other thing available from Entera that is just remarkable and priceless, in my opinion, is the group of amazing individuals that provide education. So the Entera Medical Patient Educator Group is phenomenal. I have met each one of these people, and these are trained healthcare providers who are there to answer your questions. They can help try to find a provider near you who might provide gastroparesis care. And they are there to answer your questions. There's a phone number here, and you can also access them through the website. Okay, well, I'm going to turn it over to Tracy and Vince to talk through Vince's story. And following that, we'll have a chance to do a question and answer session. And I'm happy to engage with you a bit down the road.
Thank you so much, Diana. Before we get started, before I chat with Vince, let's learn a little bit about everyone who's on this call as far as your gastroparesis journey. We're going to make a word cloud. So in one or two words, what would you use to describe you, or if you're a clinician, your patient's gastroparesis journey? And then we'll get into Vince's journey. Painful, challenging, frustrating, debilitating. Thank you for submitting. We'll see if Vince's story is similar and if his journey is similar. So I am honored to be able to interview Vince today, and I am going to pass over to Vince Roche just to give a little bit of an introduction of himself.
Hey everybody, thank you for having me. I have struggled with bowel issues since a very young age, about the time that I started to eat solid foods. This continued to about age 4, where I diagnosed with chronic intestinal pseudoobstruction and gastroparesis. I was given a Mickey G tube at 4 years old for venting and tube feeds. At age 6, I was given my very first PICC line for TPN. I have had severe nausea, vomiting, bloating, gas, diarrhea, constipation almost my entire life. These issues have continued throughout my whole life, and I currently have a femoral central line, and I get TPN 7 days a week for 10 hours a day at night. I do not currently use my G tube for feedings, just for venting and meds as of right now.
Thank you, Vince. And can you tell us a little bit about how you learned about Entera and how you learned that the gastric stimulator was an option for you?
Yeah, absolutely. So I was a little bit younger. I was about 17 and I was having severe issues. I was currently in the hospital, and a new doctor to my GI practice had rounded the hospital. I had never met him before, and it was first time meeting this gentleman, and he came in and we were discussing my symptoms and what I was going through in the hospital, and he had mentioned to me about 2 hours north of my location there was a surgeon who had some experience with the Entera therapy, installing them and giving people some relief. The next thing you know, I was headed to get an evaluation from this surgeon and was very excited to explore the new option and see how it could relieve some of my symptoms or just better my experience, my life, from what I was experiencing at the time.
Thank you, Vince. Can you share a little bit about what symptoms you experienced that were the most severe? Was nausea, vomiting, anything else? You touched on them a little bit in your opening as well. What was most severe?
I think the most severe was nausea, vomiting, like bloating, gas, and then feeling full all the time. Like, it didn't matter if I ate or didn't eat, just feeling really full. But I think nausea and vomiting were definitely the two main symptoms that were constant. And we had tried many different medications and different, therapies and different options, and it just wasn't being solved at all.
I can imagine a lot of people are thinking what symptom relief you had. So, since nausea and vomiting are the most common, and that's what you also experienced, how soon after the procedure we saw that it's 6 weeks of soreness and maybe not seeing results right away, and then 1 to 3 months going back to your doctor? What was your experience when you saw improvement?
So I was pretty sick at the time, and I almost noticed results within the first week. I'm not talking miraculous where I feel amazing, but it was a little improvement, and I could tell a little nausea was a little bit better, vomiting was a little bit better, and over the time we adjusted the settings and just got those settings dialed in, and really was able to almost eliminate most of my nausea and most of my vomiting.
Wow. And then the procedure, when Diana was sharing about the soreness, the 6 weeks, what was your recovery like from your procedure with pain and comfort level?
So I've had a couple battery replacements, but the very first one, I was stayed overnight, as like Diana explained. I needed a little bit of extra care, and they were kind of just wanted to check and make sure everything was good overnight. But within 2 to 3 weeks, I would say I was feeling less soreness, pretty much getting back to my normal life. It did take, I would say, about 4 to 6 weeks to fully be able to bend and not still feel some type of discomfort or something like that. But it wasn't too bad for me. I would say within 3 to 4 weeks, I was feeling pretty good stomach pain wise and be able to kind of interact with my normal life.
And then as far as setting adjustments, we saw that there's appointments to go in and check your settings and not necessarily expect results maybe as fast as you had. Did you have to go in a few times, and how was it with like setting to make sure you really were getting that reduction in nausea and vomiting?
Yeah, so as I said before, I seen pretty good results kind of right away. But the more and more I went back to my doctor and we fine-tuned my results, and as Diana was saying, they would ask me questions: how's your nausea? How's your vomiting? And they actually would have a sheet that would be like a 1 to 10 on a daily basis. What are you experiencing? And then we would slightly adjust my settings and I would report back to the doctor. And I would say over the first year, it really took a good amount of time to dial those settings in. But after about the first year, I really haven't had to adjust it because those first couple setting adjustments, we figured out what could work, what wouldn't work, the do's and don'ts. And then now I'm pretty much been on the same settings. I can't even remember the last time we changed a setting. It was really just checking to make sure the battery was still good and that everything was still working properly. But I haven't really changed a setting in, I can't remember, at least 5 years or so.
Well, and you mentioned 5 years. How many years have you had the stimulator?
So I'm currently 33 and I was offered the service when I was about 17. And when I finally got Entera, I was either right before I turned 18 or right after. I can't fully remember. There's so much gaps in my health that it's a little hard to remember. I know if I called my mom, she'd probably remember the date, the time, and the hour. But it was like end of 17, kind of beginning of that 18-year-old range.
And I know from getting to know you personally, you are active. Did this limit your active lifestyle in any way, especially maybe at the beginning or while you're working on the settings?
So yes, in the beginning, obviously with the surgery, that took a little bit getting used to. There was like a new implanted device, so I kind of had to figure out like how to bend, how to kind of like sleep and different things like that. Because as Diana explained, it is kind of on your abdomen. So if you like are a stomach sleeper or something like that, you could have some issues like that. But after I would say about 6 months, once they got the settings pretty much dialed in, my symptoms really started to, get a lot better. I was able to pretty much go back to almost completely normal life. Now I go to the gym 6 days a week, and I really don't have any issues or like have to alter anything because I have this stimulator. And again, that could be personal experience with my life, but I kind of don't know it's there. Honestly, after, the surgery is the pain is gone and everything's good, it's kind of just something I forget about.
So the last question for now, and then we have some questions that were also submitted before, but the last question that comes to mind is, what advice would you give to someone that's considering Entera therapy and they're maybe nervous about the procedure, the healing, change of life, so forth?
So I highly recommend the gastric stimulator, obviously because it had a lot of benefits for me. Um, and that does not mean it will be the same for everyone, but I personally think it is a route that should be offered to many patients struggling with gastroparesis. So that way they can make the right decision with their physician and see if this therapy would be beneficial to them. And if this is a route the patient and physician would be willing to try or attempt to help gastroparesis issue.
Thank you very much, Vince. Thank you for giving us an insight into your personal story and for being so open and sharing with us. And I'm sure more
Absolutely.
questions will come in. We'll close with some Q&A. I'll pass it back to you, Diana. Oh, you're on mute.
Thank you. Thank you so much, Vince. It was great to hear your story and hear what that was like for you and your journey over time. It's just incredible. I have some similar stories from my practice that are just truly amazing and inspirational. Okay, so ready to take questions. Tracy, do you have some questions to share?
Yes, so everybody who's on
Great.
now, feel free to type in any questions on Q&A. And then when you all registered, some of you submitted questions. So I'll start with those questions. And again, if you have any while you're listening or that come to mind, use the Q&A feature and we will get to those. And also, thank you for this slide with the phone number if there's anything that we cannot answer on the call. So let's see, the first few questions that were submitted. This first one is for you, Diana, I believe. So wondering if gastroparesis in Ehlers-Danlos syndrome will be discussed, as I have found this to be a very challenging population to feed orally or enterally. Any connection
Oh,
there?
I absolutely agree with you on that. Yeah, I would say that individuals who've been diagnosed with EDS, they often have overlapping syndromes, which we call as a group dysautonomia, and that is meaning the nervous system that controls all the automatic functions of the body. So those are things like your blood pressure, your heart rate. It can affect your digestive system and motility. So then when you have those disorders, you may then get diagnoses like POTS or gastroparesis, chronic constipation, pelvic floor disorder. And when I mentioned earlier about treating my patients holistically, this really comes into play with that patient population because they really do require a lot of support. They often need hydration support and nutrition support in addition to the advanced therapies we mentioned for gastroparesis. This is a patient group where I will dive into their pelvic floor disorder, their bacterial imbalance, and so it really requires a holistic approach. It's a bit outside of the scope of this talk today to kind of go into all those details, but absolutely that is an area where I think in the field of gastroenterology, in the field of medicine, we're recognizing there's a lot of overlap that needs some specific attention.
Thank you, Diana. I know we do have members with EDS as well, so I'm sure that question will continue to arise. We do have a question that came in the Q&A for you, Vince. So you had mentioned being on using the Entera device for 15 years. How has your experience been over time, like looking at year 2 versus year 15?
I think it's just gotten better. The Entera, the way they are able to find providers, the way they are doing patient advocacy now, and my whole experience, I think, has just gotten better over the years. There's been a lot more support, and there's also been a lot more knowledge that's come out, and even my doctors have like began to get new information and things like that to be able to like help myself and kind of continue this therapy.
Thank you, Vince. And the next question that came in could be for either of you, but Vince, I'm just going to throw it to you first because it's about advocacy. So if the result from the stimulator was mild to moderate, but your doctors dismiss it as like the burden of your symptoms, and those are mild to moderate, but they don't necessarily correlate. So at what severity level would you be before it makes sense to start talking about other options? So that could be for you, Vince, to advocate for that, or for you, Diana, on when you feel on the provider side, it's best to go towards the stimulator. Well, Vince, I'll give it to you first for advocating for yourself.
Yeah, as a patient, I would say you can always get a second opinion. That would be the first thing. But I wouldn't say don't trust the doctor's opinion either. I think it should be a discussion. So if that discussion doesn't go where you need it to go, talk about potentially seeking another option, another thing like that. That's probably how I would advocate for myself. I wouldn't just let it go at that point. I'm kind of hard-headed though and a little strong-willed. I wouldn't say force any ideas or anything like that, but I would say stand your ground and really trying to advocate for yourself and those symptoms and how you feel that this might be able to help you.
I could not agree with you more. And actually, this is something I'm super passionate about. And I'm really excited about this question because I am constantly sounding like a broken record here. This specific delay that is recorded on a gastric emptying study is sometimes put into a bucket of mild, moderate, and severe. But that in no way correlates with the intensity of gastroparesis symptoms. This is so important to recognize. Please do not be defeated by being labeled as a mild gastroparesis patient. Again, this is a neuromuscular disorder. And the gastric emptying test is only looking at how long it takes to get food out of the stomach, right? So if you have gastroparesis and you have mild delay in gastric emptying, that does not mean you have mild nausea or mild vomiting or mild impact on your life or mild impact on your job, your function, your ability to parent, your ability to exercise. So when we talk about a diagnosis of gastroparesis, we have defined that the stomach emptying is slower than it should be, but then we need to quantify and measure how has this affected your quality of life. And if you find that through diet and through medication support, you cannot adequately nourish yourself, hydrate yourself, or feel comfortable getting through your day, then you qualify for advanced therapy. This has nothing to do with how slow the gastric emptying test is, and it has nothing to do with how much weight you have lost. That is not a qualifying factor. There are some old archaic insurance policies that are pretty much gone. But earlier in my career, I would sometimes get a denial for a certain treatment because a patient hadn't lost enough weight from their disease. And that is completely erroneous thinking. So I really love this question. I really want to make sure that people feel supported, that your symptoms are as bad as they are for you.
Thank you for all of that, Diana. And that somebody actually in the comment brought up something similar and said, where do I find more clinicians like you who seem to know what they're talking about? And so they were looking for somebody that has knowledge as opposed to someone who dismisses their concerns. So to what Vince was saying, second opinion, do you have any advice on how they can find someone who is more knowledgeable?
Absolutely. So Vince mentioned that the care around the gastric neurostimulator has only gotten better over the years. So that actually directly has to do with Intera. I mean, Intera has taken over and has really created robust support around their care plans with this device. So for any patient who has gastroparesis, you can go to Intera's website and you can use the Find a Provider feature that they have on their website. You can enter in your location information and it will show you people who are trained to place Intera near you. Now, does that mean that Intera is right for you? No, that is still a conversation that is between you and your healthcare provider. And the idea here, though, is that this is going to help you find someone, hopefully close to home, who can do a consultation for you and help you make that decision with your local care team about whether or not this device is right for you or maybe one of the other therapies is right for you. I provide consultative services for people throughout the Pacific Northwest. People sometimes travel to see me in Seattle, and sometimes I do virtual care health in states where I'm allowed to do that. But finding an expert opinion on gastroparesis sometimes does mean that you might have to travel to a more tertiary care center in a bigger city. But I think as knowledge about gastroparesis is shared throughout the United States, and that is something I'm very passionate about, is medically educating providers on how to do this kind of care for gastroparesis. As that grows, my hope is that we can partner with local gastroenterology and surgeon providers who can provide that support and work as a collaborative team to give good gastroparesis care. But the Find the Provider feature on Intera's website is a really good place to start.
Thank you, Diana. And Vince, you had something to add? Oh, you're on mute.
Yep, I would like to say that provider, Finder Provider, has been a lifesaver for me. They're one of my the very first surgeon. He has actually now left the country. And when I was looking for a new provider, Intera had actually taken over. And this is where I was able to find a new provider. And they really have made that a lot easier than with the first couple years that I was experiencing. Finding a provider was a lot harder, but Intera has made that a lot easier. And that website specifically helped me find my newest surgeon that recently last year replaced my stimulator battery, and it was an amazing experience. So I just want to touch on that. Provider Finder has also been very improved over the years and helped me a lot.
Thank you, Vincent. We have time for probably one or two more questions. I have one here that came into the live chat, and I believe this would be for you, Diana. You might both be able to answer. So is extreme acid reflux ever a part of gastroparesis?
Absolutely. If the stomach doesn't empty, it comes up. One of the questions I ask in clinic is, think about it this way. If you feel really nauseous and you're going to throw up, throwing up is actually a reflex. It's a motor reflex in the body where lots of things have to happen in coordination and vomiting occurs. That's vomiting. Then there's something called regurgitation. And when I describe that to my patients in clinic, it's about effortlessness. When you regurgitate, something just rises up. And so, of course, with that regurgitation can come multiple symptoms. It could cause some gagging or some vomiting. It could cause heartburn. It could cause chest pressure. It could cause pain. It can cause pressure in the throat. It can cause trouble swallowing. I find that with people who suffer from gastroparesis that they need usually higher doses of acid reflux medications to manage those symptoms. And we talk about, again, diet and lifestyle. What can we do to help reduce that? Some of the best things are sleeping elevated at night if you're comfortable doing so, not eating right before going to bed, kind of working with how fluids work either between or during meals, so you're not drinking too much to rise back up after eating. And certainly that retention in the stomach is then directly related to the acid reflux symptoms.
Thank you, Diana. And Vince, you're shaking your head yes. You agree?
I couldn't agree more. All of that I was totally agreeing with.
Well, we're gonna get ready to close. Before we close, I'll pass it over to you guys to give last words and statements before we close. But first, we want to hear from all of you of your favorite takeaway or top takeaway. So we have our last word cloud. Anything that you took away from today's call. And please, everybody on the call, there's the phone number here if you weren't able to get your question answered live. So please reach out to Entera directly if you do have a question that was not answered. So in 1 or 2 words, what was your biggest takeaway from today's session? Compassionate, clinician, patience, knowledgeable. Those are all positive words. I like it. Inspiration, hope. Love that. Advocacy, voice, more knowledge. So thank you to all. So thank you, Diana and Vince. I'll pass it to you before I close, just for any closing statements, Diana, that you may have, or Vince, that you may have.
Sure. Just wanted to thank you for coming out today. I think every time we can get together to talk about the challenge of gastroparesis, we can come away with hope, with collaboration, with ideas, things to try. We talk about in this field, when we get together to talk about it, we talk about how each of these things is a try, right? We want to continue to try to make our patients feel better and more comfortable. And that comes with a long-term care relationship, follow-up visits, trying things, collaboration between patients and providers, shared decisions, and ideas going forward. So thank you again for joining us today, and I am excited to learn more from you.
Thank you, Diana. Vince, do you have any last words to share?
Yeah, I would just like to say everything that Diana just said, I totally agree with. So I'm not going to wholly repeat everything she said, but I just want to say thank you for the opportunity to be here. And Entera therapy has helped me, and I think it can help multiple other people. And see if it's the right avenue for you. And please reach out to Entera if you have any medical questions.
Thank you both. Thank you, Diana and Vince, for sharing your time, your expertise, and your personal experience. This was incredibly informative. I know I learned from both of you. And thank you so much to everybody who attended. This recording is going to be made available on our website. And our team member, John, added in the Q&A, thank you, John, oley.org/webinars for the recording. And if you're not already, make sure you're following Oley Foundation social media channels, getting our emails so that you receive updates about upcoming events, virtual and in person. Again, we have a lot of great events planned. We have regional conferences. We have annual conference coming up in Charleston, South Carolina, June 17th through 20th, and the regional in Columbus, Ohio, on March 22nd. All of our education, in person and virtual, is free to the nutrition support community for those living with nutrition support. So please continue to support us. Thank you so much. Thank you again to Diana McFarlane, Vincent Roche, and Entera Medical for this informative webinar. Have a terrific Tuesday, everyone. Bye.